So now we move on to our next session, that is the free paper presentation. And for that, we have two very senior faculty members here, eminent personalities in the field of diabetology, Dr. Shalini Jaggi from New Delhi and Dr. Ravindran from Oman. And let me just introduce Dr. Shalini Jaggi to you. Dr. Shalini Jaggi is a senior consultant diabetologist and director at Life Care Diabetes Center. She's an executive council member of the RSSDI. She has been associated with various national and international meetings. She has various research publications to her credit. And her work is primarily, she works in the field of diabetes and pregnancy. That is something she is very fond of, and she works actively for that. Dr. Ravindran A.V. Can we have the slide of Dr. Ravindran? Yes, Dr. Ravindran is a very senior consultant. He is specialist in general medicine, and he is based in Oman, and he actually helped us in bringing a lot of international delegates also. And we have a lot of registrations which have come from Middle East, Oman, Dubai, Abu Dhabi, and so a lot also the Egypt, Pakistan, Bangladesh. So I think he alone has registered more than 100 delegates. So thank you, Dr. Ravindran. We would like to appreciate you for that. And now the stage is yours. Please proceed with the paper presentation. Dr. Shalini and Dr. Ravindran, I would just like to inform one thing which we have not informed you earlier, that we are going to give a best paper award also. So both of you will decide and inform us regarding the winner.
Sure. So thank you so
now
much.
The stage is yours. Thank you so much.
Thank you so much, Dr. Amit and the organizers, Dr. Banshi, everybody for having us here. It's a great pleasure to be there in the free papers. And I think papers and research is the backbone of every conference, So I think this is where the young minds at work are able to actually think out of the box and tell us what they've done. And this is where the translation of research happens, which we see when it comes to, enabling patient support. So each candidate, we have around 11 papers that will be presented today. Each presentation, I would request everybody, each of the candidates to finish within 8 minutes. We will have 2 minutes discussion after each paper with each candidate, where we can take a few questions, if any. And then towards the end, we'll have a scoring. What we've done is we've come to a scoring system wherein 40% of the mileage, the marks will be for the scientific content of the presentation. 30% would be the translational value of what you've done, whatever research you present, and 30% marks would be for your presentation skills. So I think that would give a fair amount of scoring for everyone. So all the best, everybody, and we'll have the best paper declared at the end. I'll hand over now to Dr. Ravindran to start with the presentations and invite our presenters now.
A very good afternoon to all. First of all, I would like to congratulate Banshi sir, Amit sir, and Rakesh sir for arranging such an excellent academic feast. Without wasting much time, we will straight away go to the first presentation. First presentation is why making caregiving for diabetes easy. It will be presented by Sayonone Das. Over to you, sir. First presenter is there.
Sayoni Das, are you there? No, I think she's not logged in.
Yeah.
It's a great president, right? Introduce this time before our
Now, if somebody is not there, then we can move on.
Yeah, we'll move to the second one.
Yes, and the senior visiting consultant.
The second presentation is usage of technology in glycemic control for sub-rural diabetic patients, which will be presented by Mohammad Riaz. Over to you, sir.
I think Dr. Mohammad Riaz is also not here. So I can very well see the next presenter here. So we can start with her. And if they join, then we will accommodate them later.
Yeah. So we'll have Dr. Shaheen B. Sheikh presenting on development and evaluation of Yen-5 diabetes digital model for comprehensive and holistic diabetes care at the Yenapoya Medical College Hospital for prevention and management of diabetes. Dr. Shaheen, welcome. You're muted. You're muted, Dr. Sheikh. Organizers, can you unmute her? Dr. Shaheen, you're muted.
Okay. Good afternoon, ma'am. Thank you so much. Now I think I am unmuted. Can I share my screen?
Yes, please.
Okay. Ma'am, my slides are seen.
No. Yeah, no, it is.
Now, sir?
Yes, please. Yes, please put it
Yes,
on
yes,
full
yes.
screen mode.
Yes.
Yeah.
Now, sir?
Yes, please.
Okay. Yeah, thank you, ma'am. So, good afternoon, respected organizers, members, chairpersons, delegates, and today's speakers. Myself, I'm Dr. Shaheen. I'm a consultant diabetologist and associate professor at Yanapoya Medical College, Yanapoya deemed to be University, Darlakatta, Mangalore from Karnataka. So, first of all, I would like to thank for the World Congress of Diabetes Technology and DTechCom team for giving me an opportunity to present my work. So coming to my project, which is titled Development and Evaluation of N5 Diabetes Digital Model for Comprehensive and Holistic Diabetes Care at Yanapoya Medical College Hospital for Prevention and Management of Diabetes mellitus. So this project is basically development of digital educational portal or model in context of improving diabetes care in local and community diabetes patients, and to improve and also to provide a complete comprehensive diabetes care. So this project mainly emphasizes on interprofessional teamwork, and it's a blended approach of interprofessional education and use of communication technology in educating diabetic patients with a common goal to improve the diabetes care, and also about to improve about the diabetes knowledge and about the especially about the diet, improvement in the weight loss, physiotherapy and improvement, and improving their awareness and knowledge about the diabetes and its complications. So having said this, we will see the introduction, need of the study, and the aim. So coming to we all have been hearing about the diabetes mellitus and complications since morning, and the use of digital technology and the paradigm of changing paradigm and how the diabetes digital technology has improved the diabetes care and the evolution of this in the diabetes care. So coming to the introduction, diabetes mellitus is a major public health problem and affecting people of all the age worldwide. So digital health technology for people with or at risk for diabetes has developed at a rapid pace and becoming an increasingly common aspect of diabetes care and also in the self-management. So there are many digital health apps which are available in the market which are intended to improve the health outcome and quality of life by coaching the people, empowering the people with diabetes, supporting the health, nutrition, and weight control, and also to encouraging the glucose monitoring and maintaining a lifestyle modification by guiding them in medication dosage and ultimately reducing the complications. So here at Yanapoya Medical College, which is a tertiary care hospital, has around nearly 50 daily diabetes OPD and around 50 inpatients in different wards, and also 50 diabetes patients in all the ICUs, including MICU, SICU, surgical ICU, and step down ICU. So here 80% of the patients are from far places. So from the center of the Karnataka, who faces difficulty to visit the hospital for consultation, attend the diet counseling sessions, take physiotherapy advice, and also for the exercises, especially for frozen shoulder. And now, because during the COVID-19, it was very difficult for these patients to visit the hospital. So I felt the need of the study right here. So this project will add a new dimension of diabetes management, and which enables the greatest self-efficacy and also in understanding the disease properly. And secondly, we at Yenapoya Medical College Hospital, which is a tertiary center, do not have such digital educational portal or model to improve the diabetes care in a very approachable and also in a holistic manner. And no other hospital or institute has such a model for management of the diabetes care. So with this background and introduction, the aim of my study was to design, develop, and also to evaluate the diabetes educational digital model to empower the people with diabetes to increase their knowledge about the diabetes. So we hypothesized that this model will increase the awareness and also improve the diabetes care in local and community diabetes patients. So coming to the materials and methods, so designing and development and this thing. So first of all, we formed an interprofessional team which consisted of consultant diabetologist, information technology director, and physiotherapist, dietitians, nurses, and also a yoga instructor. Then we designed the framework of the digital educational model, and with collaboration of the Department of Medicine and in Information Technology Department at Yenapoya deemed to be university. Then study design. This is a basically pre and post educational interventional study. And the sources of data, all the diabetes cases coming to the OPD were included in the study, and the duration was from January to December of 2021. So the sample size was calculated to detect the anticipated effect size with 5% level of significance, 80% power, 35 subjects were enrolled in the study. The sample size is calculated using G-Power software. Now coming to the inclusion criteria, all the diabetes mellitus patients attending to the OPD who were using Android phone and who can read and speak and understand English were enrolled in the study. And the exclusion criteria, those patients who were not using the Android phone and who could not read and speak English were excluded from the study. The study tool, a pre-designed, pre-tested, semi-structured questionnaire was prepared by all the consultants, and I'll be showing you in the next slide. So the method of collection data was then we took a written informed consent in a local language as well as in English were taken from the study participants after explaining the details about the study. Then the data confidentiality was maintained throughout the study. Then the protocol, the questionnaire, and the diabetes digital educational model was prepared, and questionnaire and the diabetes educational model was validated for the content and reliability by the 3 subject experts. Then SRB, that is the Scientific Review Board, institutional ethical clearance, and the clinical trial registry clearance was applied and was also taken. And this is the pre and post questionnaire. Totally 21 questions were framed, and the questionnaires were framed in such a way that all the domains of the patient knowledge, education, awareness, his practices and skills were assessed. So this is the questionnaire. And then the sampling method, after obtaining the institutional educational clearance, I have recruited the diabetic patients from the OPD. We had done the pre-assessment questionnaire and also collected the blood samples for fasting blood sugar, postprandial blood sugar, and glycosylated hemoglobin. So after that, we have educated all the patients in one-to-one in all the domains, that is diabetes consultation, diet counseling sessions, were given physiotherapy, and then taught how to use the digital educational portal. We have downloaded the portal in their mobile and then educated them how to use the digital educational portal. Then after 3 months, again, we have called the patient after teaching them how to use the digital educational portal. After 3 months, we have called the patient and again did the post-assessment questionnaire test and analysis of the blood sugar of fasting blood sugar, postprandial blood sugar, and glycosylated hemoglobin. So this is the flow chart which I have prepared. care. So basically the title was designing development and evaluation of the diabetes educational portal, so which consisted of the portal I'll be showing in the next slide. So the portal consisted of diabetes consultation, basics of diabetes, HbA1c, goal of the diabetes. It has a diet section, it has a physiotherapy section, it has all the information regarding the foot care. There is also a blog section which we will be updating on the daily basis. There are videos. So videos we have framed from A to Z, like like A is for sorry. So videos we have framed from 1 to A to Z, diabetes emergency, complications of diabetes. The portal has also the OPD timings and the appointment sections. So this is the flow chart. So after recruiting the patients, we have done the pre-assessment questionnaire test and collected the blood sample for FBS, PPBS, and HbA1c. Then we have given 3 months time for getting trained on the how to use the diabetes digital educational portal, and we have done the post-assessment questionnaire test after 3 months and also collected the blood sample for FBS, PPBS, and HbA1c. So quantitative analysis was done, and we have checked, and we have found that there is an increase in the knowledge and awareness in the diabetes knowledge and awareness in the diabetic patients, and basically with the goal of patient empowerment in diabetes care. I'll be showing the results in a different section. So I'll be taking you through the digital educational portal, which is 1 minute video with all these contents. Okay, coming. Am I audible?
Yes, you are.
Yes, yes. So this was the video which I have shown about the diabetes digital educational portal, which with all the contents. Now coming to the evaluation part. So this was a quantitative study, statistical analysis. Data was entered. 35 subjects data was entered in Microsoft Excel, and analysis was done on SPSS version 27. The continuous variables were summarized using mean and standard deviation. The categorical variables were summarized using frequency and percentage. And so the normality was checked by Shapiro-Wills test, and the paired t-test was used for analysis of the continuous variable. And the mean awareness score for pre and post questionnaire awareness was evaluated for significance of differences using the non-parametric Wilcoxon signed rank test for hypothesis testing of the increase in the awareness levels. The distribution of the study variables before and after the interventions are visualized using the box plots. So the p-value of less than 0.05 was considered as significant. Now these are the results. So these are the baseline assessment and characteristic of the study population. Total number of population study participants was 35, with a mean age of 58 plus or minus 8 years. Then around 54% of the population were male and 45% of the population were female. The duration of diabetes mellitus was around 51% in 1 to 5 years, 45% in 6 to 10 years, and 2.8 were only more than 10 years were in the study participants. Then the family history of the diabetes mellitus, around 77.1% had a family history of diabetes. only 6% of the population were previously consulted for the diabetes. I mean, given the diet and the physiotherapy consultation, and 20% had the history of smoking, and 31% of the study participant had the history of alcohol intake. Now, these are the mean and standard deviation with the p-value before and after the intervention. So fasting blood sugar before the intervention, then fasting blood sugar after the intervention. So we can clearly see that before intervention, the mean and the standard deviation of the fasting blood sugar level was 179 plus or minus 48, and after the interventional, it was reduced to 113 plus or minus 16. So MBS values have significantly reduced after the intervention with p-value of less than 0.001. Similarly, in post-prandial blood sugar level, the before the intervention, it was 100 plus or minus 87 milligrams per dl, and after the intervention, it was 177 plus or minus 26.8 milligrams per dl. So the fasting postprandial blood sugar values have significantly reduced after the intervention with p-value of less than 0.01. Then similarly, HbA1c before the intervention, it was 9.
We'll have to stick to timings, please.
Yes, ma'am. And we can see the awareness level, which is increased from 55.6 to 26% after using the diabetes digital educational model. So similarly, here we have the box plots of FBS, PPBS, and which has drastically reduced after using the post digital educational portal, and we can see the awareness in the increased knowledge, and this is the distribution of the HbA1c, which has improved after using the digital educational portal. Now, coming to the discussion, in this pilot study, we demonstrated the feasibility of incorporating digital technology in the care of diabetes patients in the developing countries. Here, glucose and HbA1c have drastically reduced. Patient and physician satisfaction was improved. And basically, we hypothesized that this model will increase the awareness and also improve the diabetes care in the local and community diabetes patients. And many other studies have also demonstrated similar results of reducing blood sugar after using the digital technology. So to conclude, this designing, development, and evaluation of the diabetes educational digital model established the feasibility of incorporating digital care in the routine care of the patients with diabetes. And here more emphasis should be given on the self-empowerment of the patient with diabetes mellitus and their families, and also in the self-management, education, and lifestyle-related factors. So this study indicates the potentiality in implementation of digital diabetes educational model technologies in emerging markets. And we bring to light several issues that the diabetes community, including regulatory authorities, policymakers, professional organizations, researchers, people with diabetes, and healthcare professional needs to address to ensure that diabetes health technology can meet its full potential. Then the unique contribution of this paper was in designing, developing, and also to evaluate the digital educational portal to empower the people. And also,
could you please finish it? We're really exceeding time.
Yes, ma'am. There are several limitations. First of all, with sample size, and secondly, study duration was short. So these are the references, and I thank you, IT department. So thank you.
So thank you, Dr. Shaheen, for that presentation. Definitely a good model when it comes to education. So what I understand from this is basically this was patients came for a physical investigation, and all the investigations and everything was done. Then they were made to access this digital platform where they had access to all this reading material, right? Yes, and then so the intervention was basically accessing the platform to gain more knowledge, read about the whole read about diabetes and all these stuff that you showed, and then you did a post intervention workup. Is that the intervention that was done, or was there an active contact also with these patients?
Yes, ma'am. Actually, we started with medicine during the COVID time. So here also we did the interaction, consultation, then diet, then nurses were guiding them how to use the insulin injection, then yoga instructor was
that also part of this digital platform? So everything was done on a teleconsultation, or was it a physical plus a digital? So the education was digital education. Is that what
Yes,
you're
ma'am.
trying to tell?
Yes, ma'am. First they had come, we had a physical interview with all of them. We took the pre and blood sugars, and then we gave the downloaded the model to them.
So the education was given digitally. Rest everything
Yes.
was a physical face-to-face contact.
Yes, ma'am.
Okay. Dr. Ravindran, any comments, please?
No, madam, nice presentation, madam, and which will be of useful for all the practicing doctors.
Thank you, sir. Thank you.
Okay, thank you.
Thank you so much. So we'll move on to the next presenter. Dr. Ravindran, could you invite him, please?
Thank you.
The next topic is dynamic plantar pressure monitoring coupled with an intelligent feedback system to prevent recurrence of diabetic foot infection. To talk on this, we have Riddhi Das Gupta. Over to you, sir.
Good afternoon to all of you. I'll just share my screen.
I'll just request all presenters to stick to 8 minutes, please.
Am I audible? So good afternoon. The study today I'm going to present is a novel digital technology which helps in assessment of dynamic plantar pressures and to see whether they are able to prevent recurrence of diabetic foot ulcers in a cohort of patients from Eastern India. As we all know, diabetic foot is one of the dreaded complications of diabetes, and 40% ulcers recur within 1 year, mostly to do with alterations in plantar pressures. However, there are significant unmet needs in the management of recurrent diabetic foot ulcers. Most studies evaluate single point static plantar pressure rather than doing dynamic monitoring devices, and utilization of smart digital technology, especially in the Indian context, is still lacking. So in our study in patients with type 2 diabetes, we aim to develop an indigenous insole system that will assess the real-time dynamic plantar pressure changes over time. Combine this with a smart feedback loop to alert the patient and guide self-offloading when integrated plantar pressures crossed a particular threshold, and to evaluate this efficacy of this device in reducing the risk of foot ulcer recurrences. So we selected type 2 diabetes patients with a recent history of healed ulcerations, patients with lower limb amputations, severe PAD, active foot ulcers, and inability to walk for a certain distance were excluded. The crux of our study lies in the development of this intelligent insole system, which we have named as Prayas. This consists of an insole which is put into the footwear of the patient, and on the top you can see the sensor pod. The sides of the pressure sensors are the first metatarsal head, the lateral metatarsal head, the hallux, the lateral toes, lateral foot, and heel. After an integrated real-time data is generated, it is conveyed to a smartwatch, which is worn by the patient. The smartwatch not only gives an audio alert whenever the high pressure is detected, but it also gives a visual alert and instruction to the patient as to what he should do. And the alert continues until the pressure has been offloaded. So how does Prayas exactly work? The insole system detects plantar pressures exceeding capillary perfusion pressure of more than 35 in real-time integrated data over the previous 15 minutes at any time point, and classifies them as high, medium, or low based on the number of readings which are higher than 35. And this is then conveyed to the smartwatch which the patient is wearing. And along with the audio alert, there will be vibrational alerts and messages to the patient like walking around, cycle, sit down, and remove the weight from the affected foot, or whether the patient needs to check the footwear. The alert stops once adequate offloading is achieved over the area and the pressures are back to less than 35. The pressure data and duration of device wear were downloaded at every monthly visit to the study laptop. So we had two groups, the intervention group who received the insole along with the smartwatch, which gave them the actual instructions, and the control group, which received the insole but had a dummy smartwatch, which did not give any audio-visual alerts. So over a period of 2 years, 164 patients were screened, and finally we had 67 patients in the intervention arm and 61 in the control arm. Intention to treat was done for both of the group, and they were followed up for the period of 18 months. At baseline visit, the usual demographic profile testing for neuropathy and peripheral arterial status was done. Any new plantar occurrence was noted, as also a callus severity score at 12 distinct plantar sites was assessed, from no callus carrying a mark of 0 to severe callus carrying a mark of 3. The primary outcomes were foot ulcer recurrence between the treatment groups and the person days to actually see the estimated risk of exposure, because different people were entering the study at different time points. Secondary outcomes were adherence to device wearing, and exploratory outcomes were time to ulcer and change in callus severity on follow-up. These were the statistical analysis used. Coming to the results, the baseline characteristics were fairly matched between the two groups. Similarly, the initial foot characteristics with regards to neuropathy status, previous amputations, and ulcers were also fairly similar. Majority of the previous ulcers, as expected, was on the great toe. Coming to the primary outcome at 18 months, a total of 623 follow-up visits over 18 months yielded a total of 13 patients and 21 ulcers from an exposure of 13,786 person days in the control group, which was significantly higher than the intervention group, who had only 8 patients and 8 ulcers from 14,595 person days. Not only that, when we looked at the overall reduction in ulcer incidence rates in the intervention group, there was a 74% reduction in ulcer incidence rate between the intervention and the control group. Moving on to the secondary outcomes, the total time of device wearing was fairly similar between the two groups, with mean of around 7 hours in the intervention and 6.8 hours in the control group. However, when we looked at patients and the mean duration of usage of the smartwatch along with the insole, taking a cutoff of usage of less than 4.5 hours per day was classified as poor compliance, and this was around 26 patients, whereas 102 patients were designated as good compliers, and up to 86% reduction in ulcer incidence was seen if you are wearing the device for a minimum of 4.5 hours per day, as opposed to those who were not fully compliant. There was also significantly greater callosity risk for the controls, and the absolute change in callosity score was greatest for patients who developed a new plantar ulcer, justifying the hypothesis or the pathophysiology of how the ulcer recurs in this population. This is a very interesting data where the traditional teaching is that changes in dynamic plantar pressure usually occur while walking, but based on the time period at which the patients got the alert, we tried to look at the time period, and even simple activities like sitting at the computer, driving a vehicle, or sitting cross-legged for a prolonged period of times led to plantar pressure maladaptation and sounded the alert, suggesting that when we counsel a patient, not only while walking, but if the sitting posture is also not correct, there may be significantly greater risk of developing foot ulcers. The Cox regression analysis and time to ulcer healing was fairly similar in the two groups. So to summarize, what is the benefit of Prayas? A 71% reduction in re-ulceration over 18-month follow-up, and 86% reduction in good compliance with a usage of only 4.5 hours per day, and protection from progressive increase in callus severity, which in turn was linked directly to the chances of re-ulceration, especially at the grade 2. So what is unique about this study? This is the first developed novel Indian insole system, which not only measures a cumulative dynamic pressure over time, but also links it to a smartwatch, thus enabling the patient to have a self-directed dynamic offloading. So we are strengthening, or we are enabling the patient to manage his own dynamic pressures through this very novel intrinsically developed system. We do feel the need for further multi-center randomized trials, and of course the cost effectiveness of this technology in the wider diabetic population at risk of neuropathic ulcer still needs to be explored. Thank you.
Congratulations, sir, for an excellent study. Diabetic foot amputation is a major cause of morbidity and mortality in patients with diabetes. It is really a promising intervention. Shalini ma'am, do you have any comments?
Yes, great study, Dr. Dasgupta. I think, till now we did have methods of assessing the foot pressures. But I think a 24/7 assessment, if somebody is wearing that insole, picking up those activities which we never attribute to the development of ulcers, so making the patient understand that it is not only a faulty walking or the faulty footwear that he's using, but different postures that also can contribute. I think that's a very novel idea. Definitely much more research is required, probably larger studies, but excellent innovation. I think a great study. Congratulations.
Thank you.
So one question is, even if the so the patient is able to pick up the high pressures, the watch is giving him an alert. What are the offloadings that the patient can do himself? I mean, instead
the watch not only gives an alert, but also gives an instruction on the offloading based on the pressure which is high. Okay. Like sometimes it will guide you onto if he's sitting for prolonged periods of time and multiple alerts are sounding at then of course it will say that you need to walk around for maybe 10 or 15 minutes. If there's a defect in the footwear, if he has recently changed his footwear, or there is some object inside the footwear that is causing the pressure, then the alert will sound as to check your footwear or recheck your footwear or see whether something is inside.
So are there some algorithms there? Are there some algorithms where the patient informs the device?
No, not like that. So this is all based on, so prior to doing this study, we actually did a lot of in-house study on seeing what kind of postures and in certain individuals and what is the baseline of these pressures being generated. So real-time capillary perfusion pressure, we know that more than 35 millimeters usually predisposes to ulcer. So we looked at the specific activities both in the lab as well as in real-time data and see which are the activities that can cause these kind of pressure elevations. And based on that, we have developed the smartwatch itself has been fed with an algorithm. So suggesting that, okay, this must be the kind of activity that the patient is doing. So it will possibly pick out the best alternative out of that. So it will suggest that. Now, suppose it might happen, because this is not an interactive, like where the patient is saying, so he may actually be walking at that time, because this is still a pilot study. So then it will go on to the next advice in the algorithm. So if the patient is walking and it suggests that you check your footwear, he checks the footwear, it is fine, but still the pressure readings, the alert keeps sounding. So that means that was not the problem. So then he may advise the patient to change his posture, change his gait, or to sit for some time. And then if the alert comes down. So these are, again, some of the technological fine tuning that need to be done, for which we need more data. So we have just put this out as a proof of concept to see whether a patient-enabled approach to diabetic foot ulcer is at all feasible. Because there's a lot of inertia as to whether a patient can use digital technology, and foot ulcers is one area where it is really not picked up that much, as opposed to say, but this is more like doing a CGM for the diabetic foot, where you get a continuous reading, and like a pump, you're able to adjust. So that is what pulled us towards this idea.
So the target patient for this would be any patient with diabetes, or would it be somebody who's got a high risk foot, who's got some amount of neuropathy, probably a history of a foot ulcer or a corn or a callosity or a foot deformity?
Yes, so our study objective was to look at a reduction of recurrence, because 40% people recur within the 1 year. So we specifically took people who had a healed ulcer within the last 1 year. Okay. Now that we have the data, it would be a very encouraging sign to actually look at a primary prevention and see whether using this in a person who walks in with certain signs of neuropathy, even before he has developed an ulcer, whether this can reduce the onset of a primary ulcer. So that's something which we are now considering, provided this really, confirms to the physiology.
Great. So thank you so much. I think with this, we'll move on to our next presenter. I will invite Alok Raghav to present on the advanced glycation end products formed in diabetes possess antigenicity. His research on this topic. Dr. Alok, please.
Thank you, ma'am. I am audible, ma'am?
Just be a little more loud, please.
Okay, just I'm sharing my screen first. Ma'am, are you able to read my slides? Ma'am, my slides are readable.
Yes, they are.
Oh, okay. Thank you so much, ma'am, for giving me opportunity at such a wonderful platform.
Alok, you need to be a little loud.
Okay. Ma'am, today I am here to present my PhD work. Actually, I am a basic scientist, so I did my like research work on advanced glycation and product, which is like advanced product which is formed in diabetic condition under the presence of high blood glucose. So before the presentation, I declared the conflict of interest. It is none between the authors. So actually, I have chosen the advanced glycation and products from my like PhD topic because as we know that due to presence of high blood sugar in diabetes mellitus, there is a initiation of around 5 pathways, which is a major pathways for causing the microvascular and macrovascular complication. Like first one is polyol pathway, which induces the formation of sorbitol. That accumulation of sorbitol causes the complication. Again, the hexosamine pathway, which is again causes the deposition of glucosamine 6 phosphate sugar, like generation of reactive oxygen species, which is a causal of I think most of the diseases. Protein kinases pathway, and last one is advanced glycation and product pathway. So before actually the protein in which like in the presence of the high blood sugar, the protein having the free lysine and amino acids including the arginine, it got glycated. That the glucose moiety, it bind on the free side chain of the amino acids, and it forms first the Amadori product, which is the product of Maillard reaction. And then after the formation of Amadori product, which is a reversible reaction, it leads to the formation of advanced glycation and product. So in my study, what I did, I have chosen 5 tubes in which I have first tube is the being a control, in which just I have added the human serum albumin protein, which is an abundant protein found in the human body, and I have just kept with the PBS buffer. In all 4 tubes, I have along with PBS buffer, I have mixed the 100 mg per dl glucose, 200 mg per dl glucose, further 300 mg and 400 mg per dl glucose, and I have glycated these all tubes for the period of 40 days, and after the incubation temperature of 37 degrees centigrade. And after 41th during these 40 days, I have checked the fructosamine content like right from the day 1 to till day 40, because fructosamine is a marker of early glycation. So around day 21st, I have found the maximum fructosamine content in my all tubes, and after day 21st, the levels of the fructosamine got decreases. It is a sign of formation of advanced glycation end product. So at 41th day, I have dialyzed all these tubes, and I have removed the all extra glucose and protein from the medium. And what I found that I have collected the glycated adduct from a further study that I have characterized. And first I did my spectroscopic analysis, and I checked the UV spectra at 280 nanometer, because most of the protein like containing the aromatic amino acid, it gives the maximum absorption at 280 nanometer. So what I found that in glycated product having glycated with the 400 mg per dl glucose, the maximum hyperchromicity is absorbed. It is a sign of the structural modification occurring in the protein due to the presence of binding of glucose with the free amino acids. So actually the binding of the free amino acid, it forms the advanced glycation end products. So due to this advanced glycation end product, the structural property of the HSA normal protein got changed, and it make the protein susceptible to expose more to the outer surroundings. So after this UV absorption spectroscopy, I have checked the fluorescence, because advanced glycation end product are of two type, like fluorogenic and non-fluorogenic. So fluorogenic AGs, I have checked that the emission of 285 nanometer, and I found that maximum fluorogenic AGs are formed in tube which is modified with the 400 mg per dl glucose with containing HSA. After this, I checked with the flow THT binding binding, that is the thioflavin T binding, which is a hydrophobic dye which binds effectively with the protein aggregates. And I found that there is a maximum formation of the protein aggregates in the tube having the 400 mg per dl glucose. Similarly, ANS binding is also a hydrophobic dye which binds with the protein aggregates, and I found maximum protein aggregates in the 400 mg per dl modified glucose tube containing HSA. And in Congo red dye, I have checked the UV inspection photometry, and I have found the rad shift from the 490 to 540 nanometer, thereby confirming that there is a formation of hydrophobic protein aggregates in my 400 mg per dl glucose tube modified HSA. And after spectroscopic analysis, I did the biochemical analysis, in which I have just checked the free thiol content, free HMF, formation of HMF, hydroxymethyl furfural, carbonyl content, lysine content, and arginine content. In figure A, it is a thiol content which is having the free thiol group present in the less quantity, because most of the thiol group which is in the free in number got engaged in the glycation process. So there is significant reduction in the free thiol content. Similarly, in lysine and arginine, same trend has been observed because the free amino acid has been involved in the glycation process. Hydroxymethyl furfural in figure B is got significantly increased, and similarly carbonyl content, which is a marker of again the glycation, got increased in the 400 mg per dl modified glucose tube. After this, I have just isolated these glycated HSA, and what I did that I have chosen one rabbit model, and in these I have just induced that 400 mg per dl modified HSA, that is the AGs, along with the adjuvant. And what I found, I did the ELISA, that is both direct and indirect binding ELISA, and I found there is an immune response in against these advanced glycation end product, which is formed by 400 mg per dl modified glucose in direct binding ELISA compared to the native one, which is figure A. And after this, I have what I did that I have isolated the plasma from the rabbit, and I have just again purified the IgG antibody from these rabbits, and I again performed the inhibitory ELISA. And what I found that again the 400 mg per dl modified HSA protein showed more inhibitory concentration comparative to the native HSA. What in figure last one is D. Similarly, these are the direct binding ELISA of the isolated immunoglobulin IgG protein from the rabbits, and I found that IgG concentration in immune rabbits, which we have given the advanced glycation end product in the rabbits, and why I found that there is a increase in the absorption at 410 nanometer, which signifies that there is an increased concentration of formation of IgG in the rabbit blood against these advanced glycation end products. And after this animal study, I have performed ELISA with the clinical samples. And what I did that I have coated the ELISA plate with the 400 mg per dl modified HSA formed AGs, and then I have used the serum from type 2 diabetes mellitus patient. I found that the wells or the plate having the 400 mg modified HSA coated, showing the showing more binding comparative to the native HSA. Similarly, and while in figure B, normal healthy person is not having so much absorbance difference in both of the groups. Similarly, I did ELISA with the type 1 DM patients, type 1 DM, and similarly I found there is a strong binding of advanced glycation end product with the formed antibodies comparative to the native. And again, I have isolated the IgG from these clinical samples, and I just performed the inhibition ELISA, and I found that 400 mg per dl modified glucose HSA is having showing more inhibition percentage compared in type 2 TM and type 1 diabetes mellitus comparative to the native HSA, that is the unmodified HSA. So concluding my study, advanced glycation end products, it forms at the time period of 40 days. So these advanced glycation end product, it like alters the structural and functional aspect of the HSA protein, because HSA protein performs both like transportation of the transportation role, and also it performs the like iso it's performed the some homeostasis role in our body. So upon glycation, the proper functioning of this HSA got altered, and it forms the new epitopes, because upon the glycation of protein and after the structural changes, most of the residues, it comes out or comes in. So these comes out and comes in reaction, like forms the neo epitopes, which can be further like can be target of some antibodies, and these can also be used as a target for like diagnosis of some immunological complication occurring in the diabetes patients. And also these can be used as a early markers for like initiation of the complication in all microvascular including macrovascular complication. So acknowledgement, I like to give thanks to CSIR for giving me fellowship during my PhD work. And these studies has been published in Elsevier Index Journal in 3 journal, PLOS One, and this IJBM impact factors, all studies. Thank you.
Thank you, Alok. Definitely great research that you have done. My question to you is, we know that, higher the glucose values, more is the risk of complications, because more will be the advanced glycation end products. So what you have actually demonstrated is that these are immunogenic, and you've detected autoantibodies against in both type 1 as well as type 2 diabetics. So what is the translational value of your research? And second question is, any difference between the antibodies in type 1 versus type 2? Does this have some clinical significance?
Actually, ma'am, regarding the translational value, like if we get to know that the antibodies are forming in diabetic patient, again, like in having the more like raised glucose concentration, then apart like beside treating these diabetic patient, we can also manage these for the immunological complication. Like we can also see patients with having immunological complication if they are facing some in during the diabetes. And also like we can also diagnose these immunological complication using the concentration titer of these antibodies present in the diabetic patient. So right now I am working as a postdoctoral fellow at IIT Kanpur. So I am working on the fabrication of one device in which I have just quantifying the titer of antibodies present in the diabetic complication, including retinopathy, neuropathy, and nephropathy. So I have chosen these 3 complications first, and I have just watching the trend of the antibodies along with the concentration of the antibodies, which is like right from the newly diagnosed diabetes till the development of these microvascular complication.
So maybe I would suggest looking into the data once you have the titers of whether the antigenicity in type 1s is different from type 2s. Maybe that can in the future be used as a predictive tool to the propensity of developing complications in type 1s versus type 2s based on the glycemic levels. So maybe
actually my purpose my aim is to just like quantify the titer of antibodies, so that we can also just predict that whether these like formation of maximum antibodies is worsening the condition in diabetic patients or not, ma'am. That's why I am
how do you anticipate the difference in titers between type 1s versus type 2s? Because in type 1s we already know the autoimmune character is going to be there in patients with type 1 or patients with hypothyroid or any other autoimmune disorder. So any difference in antigenicity between the two?
Right, ma'am. Actually, you have taken the example of autoantibodies, ma'am, because like antibodies have the specific sites for the binding, right, ma'am? So if we are using like for example in type 1 diabetes, there is one insulin dependent IAA, insulin and autoantibody. So it will not bind on this like antibody which is raised by against the AGs, because we are checking the cross reactivities of all antibodies in this experiment. So and also, ma'am, every binding site is also different for all antibodies, so it will not bind. Maybe it can hamper, but we can we are looking for the cross reactivity also with different proteins.
Okay. Dr. Ravindran, your comments, please.
Yes, interesting study. And I hope that this will form a future biomarker for early diagnosis of diabetic complications.
Yes.
And even in patients with well-controlled or HbA1c in the normal range developing complications, those who are having glycemic variability also, I think these tests in future will be able to predict the risk of development of complications.
Yes, sir.
Absolutely. Thank you, Alok.
Thanks,
Dr. Ravindran, we can invite the next speaker.
Yeah, the next speaker is Dr. Tulika Ghosha. She is presenting relevance of HbA1c in diabetic retinopathy. Over to you, ma'am.
Thank you very much. Good afternoon, everyone. My topic today is the relevance of HbA1c in the management of diabetic retinopathy. I am a visiting faculty at KPC Medical College and Hospital, and this is actually one of my pet peeves. And I got the idea after doing an audit in my current hospital at the time about how often ophthalmologists recommend or prescribe HbA1c in diabetic patients. I have no financial interest. Glycemic control is the key modifiable risk factor associated with the development of diabetic retinopathy. We all know this. HbA1c or glycosylated hemoglobin is the gold standard for assessing glycemic control in diabetics. The principle: red blood cells are freely permeable to glucose, which irreversibly binds with hemoglobin to form HbA1c. The Diabetes Control and Complications Trial, DCCT, states that intensive therapy reduces the risk of development or progression of retinopathy. Glycemic control is the key modifiable risk factor for diabetic retinopathy. Both the duration and severity of hyperglycemia are the major risk factors for developing DR or diabetic retinopathy. Once DR is present, glycemic control is more important in forecasting progression. The American Academy of Ophthalmology Preferred Practice Pattern Guidelines states that HbA1c of 7% or lower is the target for glycemic control in most patients. Although in selected patients, there may be some benefit to setting a lower target of 6.5%. The purpose of the study was to assess awareness of ophthalmologists regarding HbA1c, current clinical practices regarding HbA1c estimation, and relevance in managing diabetic retinopathy. Materials and methods. This was a cross-sectional observational study. 900 printed questionnaires of 10 questions regarding the various aspects of HbA1c were circulated amongst ophthalmologists attending an All India Ophthalmological Conference. 690 questionnaires were returned. This is the 10-question questionnaire that we devised. Each question had 2 to 4 options. We will discuss each of the questions. Now let's come to the results. Nearly 61% of ophthalmologists correctly recommended HbA1c for all diabetics, while almost 1/3 chose only patients with diabetic retinopathy. Nearly 3/4 rightly said that no special preparation is needed before HbA1c testing. 80% correctly said that HbA1c provides an average of plasma glucose control over 8 to 12 weeks. Only 41% of ophthalmologists rightly chose the normal range of HbA1c as 4 to 5.6, while more than half actually chose a wrong answer. Almost 42% correctly chose below 7% as the HbA1c target for good glycemic control for patients with diabetic retinopathy, while nearly 1/3 chose below 6.5%. The higher the HbA1c, the higher the risk of developing diabetic complications. Over 97% agreed. Nearly 60% of ophthalmologists chose 3 months as the frequency of HbA1c for diabetics, while more than 1/3 chose 6 months. Improving HbA1c by 1% in a diabetic cuts the risk of microvascular complications by how much? Almost 63% of ophthalmologists correctly chose 25%. Nearly 78% rightly chose all the coexistent diseases that can affect HbA1c, that is anemia, dyslipidemia, and nephropathy. 84% of ophthalmologists correctly chose the Diabetes Control and Complications trial as the trial which recommended regular monitoring of HbA1c levels in diabetics. Discussion. Considering the first question, which I think is the most important, we see that only 60.75% of ophthalmologists correctly recommended HbA1c for all diabetic patients, while almost 31% prescribed it for patients with diabetic retinopathy. 2.8% recommended it for patients with proliferative diabetic retinopathy, and very surprisingly, 5% for all patients, irrespective of their diabetic status. The American Diabetic Association and the UK Prospective Diabetes Study recommendations showed that HbA1c should be less than 7%, blood pressure should be less than 140/90 millimeters of mercury, and A1c values should be checked at least twice a year in all diabetic individuals. The UK PDS study group says that in patients with type 2 diabetes, the risk of diabetic complications was strongly associated with previous hyperglycemia. Any reduction in HbA1c is likely to reduce the risk of complications. So, monitoring HbA1c as an indicator of glycemic control is of immense importance, which I'm sure that everyone here knows. The lack of appropriate glycemic control is a significant risk factor for the onset and progression of diabetic retinopathy. Improving HbA1c by 1% for diabetics cuts the risk of microvascular complications by 25%. So, evidence amply shows that periodic testing of HbA1c levels and its relevant timely management can help to prevent blindness from diabetic retinopathy. My take clinic messages: we need to change our current clinical practices according to our new knowledge about HbA1c. This is because of its importance in managing diabetic retinopathy patients. HbA1c can be tested at any time of the day. The frequency of testing depends on the current glycemic control, 2 to 4 times a year, so 6, 4, or 3 monthly. Ophthalmologists are requested to regularly monitor HbA1c levels for all their diabetic patients. And last but not least, endocrinologists and internists are requested to reiterate to diabetic patients the importance of regular eye examinations and to work as a team with ophthalmologists in the battle against this potentially blinding disease. Thank you, and I would just like to mention that this study has been published in the peer-reviewed Indian Journal of Ophthalmology in the Diabetic Retinopathy Special Issue in November 2021. Thank you.
Congratulations, ma'am. So it is very clear that all the other specialty people also who are involved in diabetic management has to be educated regarding the ideal or the standard of care. Absolutely. And that is important in reducing the complication rates.
Yes, I agree, totally. It's a team effort. Without, yes, I mean, just alone, we can't do anything. We all have to be in it together.
Thank you, Dr. Tulika. I think it's a good eye-opener because, you know, it is not only the diabetologists, endocrinologists, and physicians who need to be aware of doing an HbA1c for their patients, but people who actually tackle these complications. So be it a nephrologist or a cardiologist or a neurologist or even an ophthalmologist who need to be aware of the significance of HbA1c. The only limitation that I see with HbA1c is the non-standardization of HbA1c assays all across the country. You know, even in class 1 cities like Delhi, you do have a lot of non-standardized HbA1cs being done. So I think that is something that again needs to be discussed and probably thought of when it comes to prescribing an HbA1c, because now we've moved on to CGM. So HbA1c is an average. We now talk of the glycemic variability, which actually is the driver of complications. So, but yes, all said and done, those are current. I mean, in India, most of the places, even an HbA1c is still not done. So I think that is where the importance lies, in being aware of the importance of all these different parameters to assess the status of glycemic control. So thank you so much.
Thank you very much. I'd just like to mention that many diabetic patients, at least where I come from, Kolkata, they do their fasting and PP sugars monthly, but then they have 4 roshogolas a day when they go back from their office before they enter their homes. And 2 days before testing, they stop having the sweets. And so we can't find out how their diabetic control is. This is why HbA1c is so important.
Yeah, but the only problem is India has a huge amount of anemic population, and then you have all those false low and false high HbA1cs and all the hemoglobinopathies and all those situations. So I think the message has to be not only a fasting PP or an HbA1c, but maybe a more intensive self-monitoring of blood glucose in a probably a scattered fashion, if not CGM, which is easily available now, at least in the A-class cities, if not the other parts of India. Right. So I think, yes.
Thank you.
Yeah. So with that, we'll now invite our next presenter, Dr. Vikas Kumar, who is going to present his data on erectile dysfunction as a predictor of coronary artery disease in patients with type 2 diabetes. Dr. Vikas, please.
Okay. Good afternoon to everyone. And so I will going to start my topic, which is not basically what I am currently pursuing my second year in postgraduate in internal medicine, and all of you I think are my seniors. So what I had tried to did is to correlate between 2 clinical symptoms, so that we can utilize the study in a basic rural setup also. So the main purpose for this was to know the erectile dysfunction as an early predictor of coronary artery disease in already type 2 diabetic patients. So as we know that penile erection is a vascular process, and the flow through the small blood vessel of the penis is very sensitive to their function and structural changes. So a localized vascular disease, whether it's a vasculogenic erectile dysfunction, is now, we can consider it as an early manifestation for a generalized vascular disease actually. So diagnosis of erectile dysfunction and its subsequent evaluation for the serious risk or any comorbidity can help to take early intervention and preventive measure in the diabetic patients. Erectile dysfunctions, as per definition and all, I think we all are familiar, and etiology. So it can be drug-induced also, psychogenic also, and organic cause mainly are vasculogenic. Majority of cases are there. So what the basis of relationship between the erectile dysfunction, there is something called concept of the window period. Actually, in man with erectile dysfunction and coronary artery disease, this erectile dysfunction usually appear before the 2-3 years before the coronary artery disease actually happen. And this, based on this only, we have decided that can we use this to prevent the progression of atherosclerosis and coronary events, in ultimately to reduce the CVS risk. These are common, some of common risk factors that are shared between the erectile dysfunctions and cardiovascular disease. Basically, the main theme is an endothelial injury of both the disease. The significance of erectile dysfunction in diabetes is that the only most of 34 to 45% of the men with diabetes have erectile dysfunction, and this will disrupt the quality of life also. And what we have used is something called artery size hypothesis. So for a given atherosclerotic bundle, the smaller penile artery are usually which will earlier go damaged than the larger coronary arteries. And this is because of the simple reason that the small diameter of the cavernal arteries and their relatively high content of the endothelium and smooth muscle as per unit volume, is the basis that suggests that penile vascular bed is actually a sensitive indicator of the systemic vascular disease that lead to the coronary artery disease. So this is something a representation of how penile artery got of the same wall thickness got more early clogged and clinical features than compared of other artery of the system. The main aim of study was to study the role of erectile dysfunction as a predictor of CAD in the patients with type 2 diabetes mellitus, and objective was to study and examine the patients and also to know the predict the risk of the future of cardiovascular events with type 2 diabetes with erectile dysfunction. Our inclusion criteria was all the previously diagnosed patient of diabetes mellitus who were sexually active and presented with the complaint of erectile dysfunction. Exclusion criteria were less than 25 years. We have excluded type 1 diabetic patients, sexually inactive males, and basically the diabetic and with other systemic disease also we're having, we have also included, and to prevent the compounding we have excluded the smoking and drinking history. So it was a hospital-based cross-sectional observation study, and what we have done, this one, all of type 2 diabetic male patients were selected, history was taken and examined. And the investigation, which include the fasting blood sugar level, HbA1c, lipid profile, ECG, 2D ecography to assess the CAD risk, and treadmill test, and coronary angiography some patients were having, and some it was done wherever it was possible and feasible. And then we have used the International Index of Erectile Function 5 questionnaire to assess the erectile dysfunction of the patient. So this is the questionnaire we have asked. So this study was carried out at Sims Medical College, that is our medical college at Hartford, and 100 male patients were they were already diagnosed of diabetes, and then age-wise distribution was like that. So this was IEF score and mild, moderate, and severity grading we have done according to this, and erectile dysfunction. So the percentage of erectile dysfunction, actually it was increasing with age, as seen in this age group. More of above 50 years age were having around 80 to 90% of this one. Then there will comparison of we have done severity of diabetes with the severity of CAD, and then we have to know that more the glycemic control was there, so the severity of CAD was getting almost equal to the risk of severity of the diabetes. So this was a direct comparison of severity of erectile dysfunction and coronary artery disease. And the result was, in our study, in 100 of the patients with type 2 diabetes males were presented with erectile dysfunction. So most of them of 51 to 60 of years, and they are presented with erectile dysfunction and inability to basically maintain the erection during the intercourse. And then severity, as I told, this one described. The comparison of with increasing age, the erectile dysfunctions increase. Then this was severity again, as I told, the diabetes increased with the risk of cardiovascular as the glycemic control become poor and poor. And also we have found that in both erectile and coronary artery disease, the dyslipidemia was associated mainly LDL level. Usually serum cholesterol level, usually least it was associated with that. Cardiovascular risk was also assessed with this one. And so what we have got as this one, that in risk factor of erectile dysfunction are the same for the other vascular disease, and erectile dysfunction increase with the age, and estimated to have 15% of the men in age 40 to 50 years, and 45% of the men were in the 60s, and 70% of the men usually above the 70 years. So we have found a direct relationship between the increasing age and the prevalence of ED, and that was that agreement in the study, already conducted study by CGR et al. Then also we have found that in type 2 diabetes mellitus, the graded their severity according to HbA1c, and we found that severity of ED increases with the severity of diabetes. So this was again in agreement with the study of Arvind Goyal and Parminder Singh, which I have done previously, in that more than 82% of the subject with ED had a poor and very poor diabetic controls compared to other normal subjects. We also have association of dyslipidemia with both ED and CAD, and found that increasing degree of dyslipidemia, mostly LDL, associated with increased risk of ED and CAD. That was consistent with the surgery of study of Babulal Meena. So clinical importance is that recognition that erectile dysfunction can be used as independent marker for increased risk in addition to convenient other risk factor of CAD. And so the take-home message for this study was that both erectile dysfunction and vascular disease share the same risk factor, and two conditions which often coexist. So therefore, a diabetic patient complaining of erectile dysfunction should alert a physician to go through the patient to evaluate about the serious risk to take the necessary steps, intervention. So this is my references. Thank you regarding this.
Thank you, Dr. Vikas. So basically, what you have actually done is just correlated and told us that erectile dysfunction is definitely a marker for CAD, and this is something that we already have a lot of publications on this. A quick question, why did you exclude patients with type 1 diabetes? I mean, and secondly, why did you take patients only above 50 years of age? Because now we see so many young people getting type 2 diabetes, and every other day in the OPD, you will see young patients coming with problems of erectile dysfunction. So why was this important young population excluded, and why was type 1 excluded from your study?
One is in our area, the patient actually what we are getting in hospital, we have assessed before also the previous data also. More of the older age group we are getting. Okay. Then we want this one the sexually active person to be in study, and that usually was above 25, more than 25 years. That's all.
But your study, you enrolled most of them above 50, right?
But we study like the severity increase when it was more than 50 and 60.
Okay. Thank you. So Dr. Ravindran, quick comment and we'll move on to the next one because I think we're running late.
Yes, it's already a recognized factor that these conditions produce endothelial dysfunction leading to erectile dysfunction and for future cardiovascular risk. So all patients with erectile dysfunction should undergo cardiovascular evaluation. I think, madam, you are muted.
Yeah. So I think we'll move on to our next presenter, Harshad Malve, who will talk on the knowledge, attitudes, and practices on oral fluids, electrolytes, and energy management in various acute non-diarrheal illnesses in Indian physicians. Harshad, are you there? No. Okay. So next one, Dr. Ravindran, you can invite her.
Yeah. Next speaker is Mayuri Talati. She will be talking on Beat Diabetes, Win Life. Over to you, ma'am.
Thank you so much, sir.
Everyone kindly stick to 8 minutes presenting time, please.
My screen is visible in full screen mode.
It's not yet full screen. It's visible, but yeah, now it's clear.
Okay. Good afternoon to all. I'm Dr. Mayuri Talati from the medical team of USV. I take this opportunity to thank Dr. Amit Gupta sir as well as the entire DTechOn team for giving me an opportunity to present at the prestigious World Congress of Diabetes Technology 2022. And not to forget, wishing a very happy Mother's Day to all the mothers out there. So, Beat Diabetes Win Life. Coming to the background, today the rule of 50% is prevalent in terms of diabetes awareness, detection, treatment, and control. In fact, 1 in 2 Indians is unaware that they have diabetes. Even recent IDF Atlas 10th edition data shows that 53.1% of the people with diabetes in India are unaware. And as per TIDE study, 77% of these type 2 diabetes patients are uncontrolled. Continuous and affordable access to treatment and education remains a major problem. Hence, awareness about risk factors is a prerequisite for the prevention of diabetes and its related complications. So, Beat Diabetes Win Life is a unique initiative undertaken by USV to achieve an inspirational target of 90-90-90-90, wherein 90% of the people with diabetes should be made aware, 90% of those aware should be detected, 90% of those detected should be treated, and 90% should be at goal. So, what are the components of Beat Diabetes Win Life? At the awareness level, so we have targeted different populations, say from general to those with moderate and high risk of diabetes to newly diagnosed. So at the awareness level, for the general population, we have various initiatives like the online Indian Diabetes Risk Score Assessor. Then we have Disha and Facebook Live patient awareness videos. For screening and diagnosing people with moderate to high risk of diabetes, again, we have the online Indian Diabetes Risk Score Calculator, as well as various Beat Diabetes camps. So these camps are for glucose testing, HbA1c, as well as complications. And at the treatment and control level, for newly diagnosed and patients with known type 2 diabetes, we have DECC, which is the Diabetes Education Certificate course. Also, we carry out various RSJ CMEs, then the Indian Diabetes Educator Journal and National Diabetes Education Program. And to keep the patients at goal, also we have the Diabetes Education Certificate course along with Diet Assist and IDEJ and NDEP. So today we'll focus on Diabetes Education Certificate course, which comes under Beat Diabetes Win Life. So the aim of my study was to assess the impact of Beat Diabetes Win Life, Diabetes Education Certificate course on the patient's knowledge regarding diabetes and its complications. A Diabetes Education Certificate course was provided for patients under the umbrella of Beat Diabetes Win Life. There were 12 modules containing approximately 8 to 10 multiple choice questions each. And the various topics which were included were as follows. They were divided into 3 parameters. One is glycemic, the other one was related to complications, and the third one was safe feasting and fasting, healthy habits to reduce high blood sugar, self-management of blood sugar. Under the glycemic parameters, the topics included were basics of blood sugar, understanding high blood sugar monitoring, under complications, high blood sugar, know your risk, high blood sugar, heart kidney link, diabetes and food care, and so forth. Each module also had a patient education video specific to the module. So prior initiating to the module, participants' knowledge was assessed. The participants' knowledge level was captured before as well as after completion by a 4-point rating scale from not aware, partial, basic to advanced. So this is the login page for the patient. This is the first snapshot shows where they are rated for their current knowledge of diabetes. And then there is a video at each module before starting the module. And after going through the video, then they have those set of questions for that module, and they are tested accordingly. And then they are given a badge once they complete each module. So there were around 765 participants when we initiated this. Now there are almost 10,000 participants who have enrolled. And before the course, most of the participants were either at the not aware or basic stage. However, after completion of all the 12 modules, there was an 81% increase in the knowledge from basic, not aware, and partial to advanced for all the modules. So this is the graph which shows the % change in knowledge of participants after completing all the 12 modules, 81% increase. And this is the % change in knowledge at the end of each module. So here, if you have a look, there was maximum change from basic to advanced at the 9th module, which is medication adherence, followed by diabetes and food care, module 6, and then module which talks about high blood sugar, know your risk, and heart kidney link. So to sum up, Beat Diabetes Win Life Diabetes Education Certificate Course Program assesses the patient's knowledge and awareness of diabetes and its complications. And it was seen that the patient's knowledge and awareness of diabetes and its complications increased. There was an overall 81% increase in the knowledge and awareness from basic to the advanced level. This is also in line with similar awareness programs which are taken by other scientific bodies, such as the Defeat Diabetes campaign, which was initiated by RSSDI to create awareness among the general public regarding importance of screening and regular monitoring of diabetes. So Beat Diabetes Win Life program will help people not only manage diabetes better, will encourage them for self-monitoring, regular blood glucose check, improve adherence to anti-diabetes regime, as well as regular follow-up with the doctor, and enable healthcare teams to manage diabetes patients more efficiently, resulting in improved quality of life for people with diabetes. What is so unique about Beat Diabetes Win Life? Free of cost, available in 12 regional languages, have 12 patient educational videos, as well as the ease of use. So the Beat Diabetes Win Life program would form an integral part of achieving the inspirational target of 90-90-90-90 for making India diabetes care capital of the world. When every institution strives toward a single mission, nothing is impossible. Mission 90-90-90-90. Thank you so much.
Thank you, Mayuri, for that excellent presentation. I think as practitioners in India, most of us are very well aware of this mission. And I must congratulate USV for actually indulging into patient awareness and helping us as healthcare practitioners reach out to our patients, to achieve the common goal of 90-90-90-90.
Thank you, madam.
So with that, thank you very much. And we'll move on to our next presenter, Dr. Avijit Saha, who's going to present his research on clinical subtyping of newly detected type 2 diabetics on the basis of pancreatic beta cell dysfunction and degree of insulin resistance and their clinical characterization. So Dr. Avijit, please. Dr. Avijit, we can't hear you.
Yes, ma'am. Can I audible now?
Yes, please make it full screen mode and then you can present.
Well, hello everyone. Good afternoon. Myself, Dr. Avijit Saha, and thanks organizer for giving me this opportunity. The title of my presentation is Clinical Subtyping of Newly Detected Type 2 Diabetics on the basis of pancreatic beta cell function and degree of insulin resistance and their clinical characterization. To introduce the topic, we all know type 2 diabetes is a heterogeneous disease in its etiopathogenesis and clinical presentation. And we have learned so far 8 to 12 different pathophysiological defects that are contributing to blood hyperglycemia in type 2 diabetes, that is from omnious octet to dirty dozen of diabetes. But still, at the same time, some evidences are emerging that some of these defects are resultant of chronic hyperglycemia rather than having causal relationship, like incretin defect. Once the hyperglycemia is reduced or euglycemia is achieved, incretin defect alleviates. So we probably the pancreatic beta cell secretory defect and insulin resistance continue to be the most significant determinant of type 2 diabetes.
Please,
and basically,
slides are not moving and it is not in slideshow mode.
So I have.
Yeah, just make it full screen mode, please.
Yes, ma'am. I have.
Maybe you can unshare and share it back.
Okay. Okay.
Stop share and then share it back.
Okay.
Yeah, so you can share it back now.
Is it visible now?
Yes, yes.
So may I start from starting or from the background?
No, you can continue from here. We've heard you.
Okay, okay. So basically, whatever forms of diabetes it is, at the end of the day, it is a basically simple imbalance between the insulin secretion and insulin resistance. And what is the rationality behind giving a diabetic patient insulin secretagogue without having any knowledge regarding his or her beta cell reserve? While EASD ADA recommended to consider various comorbidities while choosing anti-diabetic drugs, but they didn't mention these basic endocrinal defects of type 2 diabetes. So, with this background knowledge, the present study was done with the following objectives. Number one, to estimate the degree of insulin resistance in the form of HOMA-IR, and to estimate the pancreatic beta cell functional capacity in the form of HOMA-beta among the newly detected type 2 diabetic patients. And number two objective was to subclassify them on the basis of this functional assessment. And we also tried to look into their clinical and laboratory parameters, and also to calculate the correlation of this HOMA-IR and HOMA-beta with the anthropometric sugar and lipid parameters. This is the way we have done the sample size calculation, where the Z value was taken 1.96 with a 95% confidence interval. With the precision of 0.05, the sample size calculated was 95. Another 5% was added, considering the non-respondent rate. So the final sample size would be the 100. This is the methods. This was an observational cross-sectional analytical study done with the outpatient of the diabetes clinic of our institution between the March 2022 to December 2021. And we have included all the newly detected diabetic patients who came first time in our clinic for initiation of the drug therapy. And those were between the age 18 to 75 years and who were presented at the same time in the stable metabolic conditions. The exclusion criteria were all other forms of diabetes like type 1, GGM, secondary causes of diabetes, and also those who presented with concurrent illness and metabolic decompensation. We did not include them. This is the HOMA2 calculator by which we have calculated where after putting the patient's fasting plasma insulin and fasting plasma glucose, we got the individual's pancreatic beta cell functional capacity in the form of HOMA-beta value and patient's individual's degree of insulin resistance by the HOMA-IR value, and HOMA-beta value below 50% we have considered as poor beta cell functional capacity, and HOMA-IR value above 2.5 or more we considered the individual having significant amount of insulin resistance. Now the results, the mean age of the study population was 45.55 plus minus 11.64 years. 58% of the study population comprised of males, and the mean BMI calculated was 25.93 plus minus 4.39 kg meter square. And these are the mean HOMA-IR and HOMA-beta values. By the figure 1, I have shown the distribution of HOMA-beta value in the study population, where you can see the 39% of the study population had HOMA-beta value below 30%, and 32% of the study population had HOMA-beta value between 30 to 50%. So putting this together, 71%, that is more than 2/3 of the study population had HOMA-beta value 50% or less. And by the figure 2, I have shown the distribution of HOMA-IR value among the study population, where we can see the 49% of the study population had HOMA-IR value below 2.5. That means they had insignificant amount of insulin resistance, and 36% of the study population had HOMA-IR value calculated between 2.5 to 4, and about 15% of the study population had HOMA-IR value more than 4. So taking this together, around 51% of the study population had HOMA-IR value 2.5 and more. Now we have calculated correlation, Pearson correlation between the HOMA-beta and with the various parameters, and we have found HOMA-beta was positively correlated with the abdominal circumference, and it attained statistical significance. And we also found the HOMA-beta values were negatively correlated with all the sugar parameters, that is fasting, PP, and the HbA1c values, and all these attained statistical significance. And by this table 2, I have shown the correlation of HOMA-IR between the various parameters of the study parameters, and where you can see the HOMA-IR was significantly correlated with the abdominal circumference, and it was negatively correlated with the HDL cholesterol, and this also attained statistical significance. But we did not find any meaningful correlation of HOMA-IR with the sugar values. Now we have subdivided the study population into 3 subgroups. One group where the insulin resistance predominant, that is they had higher HOMA-IR values, and the Number 2, beta cell dysfunction predominant group, where they had the lower HOMA beta values, that is less than 50%. And the last group where the both abnormalities exist. That means they had higher HOMA IR values, 2.5 and above, combined with lower HOMA beta value, that is less than 50%. And in our study population, insulin resistant predominant group comprised of 30% of study population. Beta cell dysfunction predominant group had 45% representation of the study population, and the both abnormalities exist group comprised of 25% of the study population. And surprisingly, all the entire study population having the same disease, that is type 1 diabetes, they are different from each other in terms of their anthropometric measurement parameters, in terms of their glucose parameters, in terms of their lipid parameters as calculated by the ANOVA technique. And we found that insulin resistant predominant group had the highest BMI, abdominal circumference, highest blood pressure, and also they had highest fasting C-peptide, fasting insulin level, higher HOMA IR and HOMA beta values. Whereas beta cell dysfunction predominant group had the lowest BMI, lowest abdominal circumference, and the lowest fasting C-peptide, fasting insulin levels. And at the same, and both abnormalities group had the highest sugar values, that is fasting sugar, fasting and 2-hour PP sugar, and the HbA1c. And their other values were intermediate between the values of the other two groups. And both this, all this attain statistical significance. Now, a little bit of the review literature. The Anjana et al. Subdivided the diabetic population into 4 novel subgroups depending upon the 8 clinically relevant variables. That these were age at diagnosis, body mass index, waist circumference, their HbA1c level, triglyceride, HDL cholesterol, and fasting and stimulated C-peptide level. And they got 4 distinct subgroups. One is SID variety, that is the severely insulin deficient group. Another was IROD, that is the insulin resistance obese group. And another was SIRD group, that is the combined insulin resistance and deficient group. And a MARD, that is the mild age-related diabetes group. Regarding the limitations, it was a single center study. We measured the beta cell function and insulin resistance by the indirect method. As we all know, the gold standard method for detection of these are the hyperinsulinemic euglycemic clamp method. And we also did not measure these parameters serially during the course of time. As we all know, the diet, the drug therapy also have influence of these parameters. And HOMA2 calculator has its own limitations, like when the sugar values are very much variable, when the very high sugar values are present, and also the patient having very low, poor beta cell functional reserve, the HOMA2 calculator derived values parameters were unreliable. So I conclude our study demonstrated by the time of diagnosis of type 2 diabetes, more than 2/3 of the study population had less than 50% residual beta cell function left, and more than half of the study population had significant degree of insulin resistance, and increased abdominal circumference and low HDL cholesterol was positively correlated with the HOMA-IR. So they can be the clinical surrogate marker of insulin resistance. And we did not find any significant correlation of HOMA-IR values with the glucose parameters, but these glucose values parameters were significantly negatively correlated with the HOMA beta values. So probably the pancreatic beta cell secretory defect must set in for the clinical occurrence of overt type 2 diabetes. And so only the insulin resistance may not be synonymous with the type 2 diabetes. And it is this beta cell secretory defect may be the major determinant of the blood glucose values. And every diabetic patient is different from each other in terms of their pancreatic beta cell functional reserve and degree of insulin resistance. And this kind of functional assessment will be helpful while we are going to treat the type 2 diabetes with the way it is. Thank you.
So thank you, Dr. Saha. That was a good study. Of course, what you've used is HOMA beta and HOMA IR. The only thing is patients who are newly diagnosed with type 2 diabetes, there's already uncontrolled hyperglycemia, glucotoxicity, lipotoxicity, and we all know if you do an assessment of something like a C-peptide, probably you will have a low value, and once the glycemic parameters stabilize and the glucose is controlled well, you do see an improvement in the C-peptide. So the HOMA beta tends to improve again, So any which ways, I think your subgroups do fit into Dr. Mohan's subgroups of severe insulin resistance and the both the defects present and the beta cell dysfunction there. So the clinical translation that you are saying is at the diagnosis of diabetes. So how do you want to use this as a clinical model for deciding on the therapies for your patients?
Yes, ma'am. Because I want to convey this message that, madam, before we are while we are going to select the drugs from the available long list, at least we must have some certain knowledge of patients' beta cell reserve and the patient's degree of insulin resistance. And it is as we all know, the gold standard method, that is the euglycemic hyperinsulinemic clamp method, is not possible to apply in day-to-day clinical practice.
But then doing a HOMA IR and a HOMA beta, I mean, in a clinic, in a medical college setting or a research setting, yes, that is possible. But in a normal day-to-day clinic, do you think an assessment of HOMA beta and HOMA IR for each patient is required when you get a patient with new onset diabetes to decide on the kind of treatment that we want? And how much is the standardization of HOMA beta and HOMA IRs all across the country and different labs in the same cities? So do you think that's a viable option to actually subject every newly diagnosed patient with type 2 diabetes to a HOMA beta, HOMA IR, classify him into this, and then decide on the therapy you want to choose?
No, madam. But if we have the opportunity to get this information, we can adopt this, because it will be more logical approach to select the drugs.
Right. Great. So thank you so much. Dr. Ravindran, you can invite the last speaker.
Thank you, madam.
Okay. The next speaker is Dr. Sachin Misra. He will be talking on EMR is the best tool to fight against medicinal non-compliance. Over to you, sir.
Am I audible?
Yes, Sachin.
Yes.
So firstly, a very big namaste to both the chairpersons, madam and sir. And I just thank all those Gurujis who just asked, who just gave me this opportunity to present a paper out here on the DTechOn. And as this is a technological congress, I just decided to present a paper which just starts with the technology. It is the EMR. EMR is the best tool to fight against medicinal non-compliance. It is a very short study which I did at my center, the Unicentric study. And here what the background, what I got before doing this study was the recent advancement in technology during the crucial fight against COVID-19 also helped to develop EMR. Yes, this is a point. Yes, due to these COVID fights, these teleconsultations, telemedication apps and all, we just rushed into these EMR facilities. But the main process was how this EMR maintenance was taken care of, and through an app created a technical reachability for both doctor staff and diabetic friend. So the recent inclusion of EMR at diabetes OPD improves many factors, which ultimately leads to a quantitative improvement in glycemic status. This is the background of my very short study. And the aim of my this short study was to assess the effect of EMR on diabetic population with medicinal non-compliance. The group which I decided was any kinds of medicinal non-compliance diabetic friend. And through this, I just wanted to connect how can EMR help and act as the main keynoting factor. So methods and materials which I thought that would be the best for this study was prospective cohort study conducted from 2021 September to 2022 January, that is almost near about 4 to 5 months, amongst diabetic population with nearly same glycemic index with baseline HbA1c 9.5% and nearly same ongoing treatment strategy. Same ongoing treatment strategy means the patient who were insulinized were assessed on the basis of insulin and all those glycemic status, and on OHAs were assessed accordingly. While selection of the cases was made on the basic criteria of medicinal non-compliance issues. So 50 diabetic individuals with common habit of medicinal non-compliance as the first. Secondly, not active regular follow-up statuses. Thirdly, regular measuring of blood sugar levels and other vitals not performed at all. So these were the three basic concerns for my studies, and newly introduction of EMR with proper counseling and education of app and its usage. Basically, it was just not counseling, it was the proper education of the usage of that app, which I gave to my diabetic friend along with the proper telecommunication at regular intervals. So what I got, the final results, what I got during 4 months of this short study, various factors was assessed in these 50 individuals. The EMR and app regular usage was found effective and improved. What it improved was HbA1c by 0.5 to 1.3%, which is a good value, I think. Now, apart from HbA1c, what I think was the two main facts of introducing EMR at my clinic and thus creating studies was improved regular follow-up profile as indicated on the EMR, and prescription with proper notifications that when that diabetic friend has to come, with proper goals that how he has to come, when he has to measure his blood sugar levels before coming to the diabetic OPD and reaching to his physician or diabetologist or endocrinologist. And the biggest point of this slide, this result slide, is issues like when to take medicine or insulin, how to take medicine, and how long to take medicines were solved by clear, crisp Hindi and English forms of my EMR app. And thus, what I think that I just separated my diabetic friend from the confusions. Firstly, the mediocre writing of our doctor fraternity. Firstly, secondly, the ununderstandable language of the medicines, when to take it and how to take it, and thirdly, the misconceptions which are now very nicely made by the medical hall or those medical store people while writing when to take the medicines on the envelope of that medicine. So these points were very nicely taken into care by the EMR app, teleconsultation and telemedication with all the kinds of regular follow-up services. Now, into my study, 46 individuals were regular at follow-up, firstly, out of those 50. And in these 46, grossly 100% positive rates for medicinal adherence improvement in all near about 50 diabetic individuals was recorded. So what I conclude that treatment strategy and glycemic status improves with introduction of EMR with diabetic individual. Regular follow-up, time-to-time medication, and exactly same medications that what we are prescribing are the newly achieved target in terms of treatment strategy with EMR, electronic medical records. Sometimes we search for something and we get a reward too. Here I got a weight reduction in my selected diabetic individuals as a result of regular consultations through app and regular diabetic educations through my diabetic educators, through diabetic dietitians, all those clinical helpers, which always help my diabetic individuals through this diabetic EMR app only, so that there can be a very good glycemic status improvement. So at last, the final what I can say result and sentence of my study was medicinal adherence and education about diabetes improves by 100% when in correlation with EMR and app usage. So thank you, DTechOn 2022. Now a line from my side that making the change needs the first change at my self level. So at my self level, I have developed an EMR app. I have named it as EMR only, not a second name as EMR. Now bring an EMR, make diabetes as digital diabetes. With these kind words, I thank both the chairpersons for letting me speak here about my abstract. Thank you, ma'am, and thank you, sir.
Thank you. Such an excellent presentation. And I think this is something that all of us have learned, especially now with the pandemic. I think the optimal use of technology, we all had EMRs, but how to use those EMRs, and eventually the way we have started banking on technology, and we're seeing an improvement in outcomes. So that's a commendable job. That I think one positive thing that we've learned from the pandemic. Dr. Ravindran, your views?
Yes, this is a nice information, and we are all using EMR. And I would like to know, this is the EMR created by you?
Yes, sir.
Designed
I
by-
created myself, though I
yeah.
first practiced 2 or 3 sets of EMR through these, just like DoQuant, Practo and all. But now I have created myself and named it as EMR only.
Okay. Congratulations and all the best. Okay. And one thing I wanted to know, from the EMR, can you directly create a master chart?
Yes,
is there any option like that?
So what I have done is, according to the treatment profiles, I have just what I listed is 40 to 50 treatment strategies or templates, which I can broadly say. These templates, for example, there are 2 OADs and an insulin, a basal insulin, or 3 OADs or anything. So there are templates for those diet charts according to the age. So, for example, my diabetic educator suggests that here Dr. Sachin has written 3 OADs with a baseline insulin, and this patient is 74 kgs and his age is itna. Then, according to that age-specific criteria, with weight-specific criteria and treatment-specific criteria, that diet chart will be given according to the template only, sir.
Yeah, that is great, because most of the EMR now, there is no option for direct creation of master chart. We have to calculate the data.
And this was the only and suggested reason why I chose to develop my EMR diabetes, because I also face the same. These EMR apps, what they gave, the traditional diet charts, the traditional advices, which differ from person to person when we treat diabetes as individual.
Great.
That is great. Yeah.
So thank you. We've had some excellent paper presentations. We have sent our scores to the organizers, and you'll probably hear about the results in the final felicitation ceremony in the valedictory. So I would definitely ask all of you to log in for the valedictory function, and I'm sure Dr. Banshi will be announcing the winners. We've had great scientific presentations, excellent science being discussed. Thank you so much. It was great listening to those presentations, and thank you, Dr. Ravindran, for being such a great chair. Thank you.
Thank you,
so
ma'am.
much,
Thank you, ma'am.
Thank you so much, sir.
Thank you, organizers. I hand it back to you now.
Thank you all the presenters. It was very nice, and I would like to thank the organizers, especially Banshi sir, Amit sir, and Rakesh sir, for giving me an opportunity to chair this session. Thank you all.
Thank you, everyone, very much.